Well, good morning, everyone. My name is Mary Bauman. I'm joined by my colleague, Tripp VanderWal, and we're delighted that you could join us for today's webinar. We have about 400 signups, and they are from all over the country. I believe that we have 15 different states represented, so that's pretty cool. The first thing we're going to talk about today is the fact that we have some just a quick revisit on the 1094C and 1095C filing requirements. Tripp?
Good morning, everyone. Yeah, so as Mary said, we're going to quickly touch on some of everybody's favorite thing to do is the 1094 and 1095 filings. As you can see here on this next slide, the deadlines for these are typically set with the same deadlines as the Form W-2s, meaning that they typically have to be distributed to your employees by the first business day on or after January 31, and then filed with the IRS if you're filing in paper by the first business day on or after February 28, and electronically you get it another month on the first business day on or after March 31. As most of you probably remember or are aware, we got some extensions for this last year, which was nice, and we found out about that in January. Unfortunately, this year, while we do have some extensions, we don't have as generous extensions as we did last year. There are no extensions of time to file with the IRS. So when you are filing with the IRS, as of today, you are still required to file by February 28 if you're filing in paper, and by March 31 if you're filing electronically. However, in November, the IRS announced that when it comes to giving these forms to your employees, you do have an additional month. So instead of being required by January 31, you have until March 2017 to give these to your employees. The other addition that the IRS extended in November was this idea of good faith filing or good faith reporting, which says we will not, the IRS basically says, we will not assess reporting penalties if you make a good faith effort. But that good faith effort only applies to timely filed returns and will exempt you from potential penalties for incorrect or incomplete returns.
So I think, Tripp, the question is that maybe on the minds of many of the folks on the call today is, will the Trump administration further postpone either the employee statement deadline or postpone the IRS filing deadline? What are your thoughts?
That's a great question, and frankly, one I don't have a great answer for, because I think, while we've heard a lot of talk about what changes are potentially coming to the ACA, they haven't really, dived into the minutia, and I would call this reporting the minutia. So they haven't talked about whether the good faith will be continued year after year, whether it will be a continued extension. So I think at this time, the appropriate response is to move forward planning on that these deadlines, the original deadlines for filing the IRS and the 1-month extension for giving these forms to your employees is the most appropriate way to proceed.
Yeah, I really agree with you, Tripp. I think that if you look at the political climate right now, the focus of repeal and replace that we're going to be talking about in just a few minutes tends to be on the individual and tends to be on the marketplace and where they're going to go to get insurance. Frankly, the concern about employers seems to be a lesser concern. And so with that in mind, and also the fact that we're going to probably see some type of transition in repeal and replace, and with all of those factors in mind, my guess is that 2016 reporting will be ultimately required, maybe another postponement, but not probably lengthy and certainly not a reprieve. Tripp already mentioned this good faith relief, and this slide just goes into that a little bit more. But again, the guidance that we received in November said if you file an incomplete or incorrect filing, not only do you get reprieve from the $260 per return penalty, but you get it not only for last year, but you get it for this year too. And I think we've kind of already answered that question as well, and that is probably the same type of prospect, maybe an extension of this for 1 more year, but again, who knows what's going to happen with repeal and replace. Are there any changes to the forms for this year, Tripp?
There are a few changes to the forms. The good news is, excuse me, I skipped over one slide. There we go. Is they're very minor and not a big deal. So as you can see, the first changes we discussed are the changes to the form 1094C, which are the transmittal form. And the changes really only apply to if you're one of those mid-sized employers or other employers that's claiming some type of transition relief. There's potentially ways that you have to modify the way you fill out your form, and that's because that transition relief only extends into your 2016-2017 plan year. So once you're, your 2015 to 2016 plan year. So once your 2016 plan year started, you no longer are eligible for that transition relief. And then some of you may have used this qualifying offer relief, the special relief for 2015. I don't know of many of our clients that did that. If you did, that has been eliminated. With respect to the Form 1095C change, I think more than changes, there were really clarifications. There's now a clarification in the instructions that go along with the form that the recipient doesn't have to attach it to their tax return, but they, of course, should keep it with their other tax documents. The plan start month, so if you have what month your plan year starts, that box is still going to be optional for this year. So if you completed it last year, and you can do it again, go ahead, but don't feel the obligation to do that. Line 14, they clarified that you need to have a code in all 12 months box, or if you don't, in the all 12 months box. So you either have to have a code in one in every month 12 times, or in the all 12 months box. I think most people were pretty clear of that, but they further clarified that in the instructions.
So on the other hand, though, Tripp, it's possible that an employer might not complete all or part of lines 15 or 16.
Correct. Line 14 is the only one out of 14, 15, and 16 that you do, in fact, either need to have something in each individual month or in the all 12 months line. Probably the biggest change with respect to line 10 or Form 1095C is if you are a employer that has what we call a conditional spouse offer, meaning that you offer coverage to your employee spouses only if they don't have an offer of coverage from their own employer. There are special codes to report that, and as you can see, those are 1J and 1K. A few things to note about that: these are only appropriate if you are actually conditioning eligibility and not opposing a surcharge. So some employers may say, yeah, we offer coverage to employee spouses, but if they have that other offer of coverage to their own employer, they can still come on our plan, but they have to pay a penalty to do so, or maybe have to come on a secondary basis. Those codes are not appropriate to report those arrangements. It is solely to report conditional eligibility. If you do have a spousal...
so in other words, Tripp, that would mean if I say you can't enroll in my plan if you are eligible for other coverage, or eligible for other coverage as a full-timer, or eligible for other coverage that is affordable and how we determine affordability, all of those kinds of rules would constitute a conditional offer.
Correct. Absolutely correct. And then going forward, I think a few things to know, or one specific point to note that wasn't clear, but we have clarified through informal guidance with the IRS. If you have a arrangement in which you condition eligibility on the employee spouse not having an offer of coverage, and you were previously using the qualifying offer code, which is code 1A, you are no longer making a qualifying offer, at least with respect to reporting purposes. So if you used 1A last year and you have this spousal conditional offer, you can't use 1A this year. The appropriate code is 1J or 1K. Finally, a question arose kind of at the end of last year. If I do have a qualifying offer, again, that's using code 1A in line 14, we really didn't see the purpose of why you had to complete line 16, but the instructions didn't say you could omit it. This year, the instructions, or I think it's the actually frequently asked questions, say if you use a condition, if you have a qualifying offer, so again, you're using that code 1A, it's up to your discretion to complete line 16. For example, if someone waives coverage and you're not required to put in the fact that you use the rate of pay affordability safe harbor.
You mean federal poverty.
Federal poverty line. Excuse me. I'm sorry. Yes, federal poverty line safe harbor. If you're using the rate of pay, you didn't make a qualifying offer.
That's exactly right. That's exactly right. Okay, and this is really we included these next couple slides just in your materials because we thought it would be a nice takeaway for you, but we're not going to spend a lot of time on this because we really want to jump into the legislative proposals. Just a reminder, every year it's possible for changes to be made based on cost of living adjustments. They're not always made, but sometimes they are, and sometimes they're announced well in advance, like in the case of the HSA rules. Other times with medical flexible spending accounts, if you're a calendar year plan, you may have already begun your open enrollment process, and you heard that, oh, darn it all, they just increased to $2,600. So these are just for so you can go up to these limits, but they're not required. For example, in the case of the medical FSA, you can see there that the HSA annual contribution limits are pretty much the same, just one little change there on the single coverage tier. And then the maximum out-of-pocket limits, these are the ones for 2017 for all grandfathered plans. That should be all non-grandfathered plans, actually.
Correct.
That's a little bit of a typo there. Sorry about that. And then the second is for high deductible health plans with health savings accounts, which has a little bit of a lower maximum out-of-pocket. And then finally, for those of you who do determine affordability under the pay-or-play based upon the federal poverty line safe harbor, I just thought I'd do a little math for you to show you that for calendar year plans for 2017, the federal poverty line would translate into an amount of $95.93 per month for single coverage under your cheapest medical option providing minimum value. What about some of the fees, Tripp?
Well, and we'll quick cover these again as an overview. You know, the good thing about the transitional reinsurance fee is it only applies for calendar years 2014, 2015, and 2016. So we are now in 2017. So the transitional reinsurance fee has gone away. So you should have completed your transitional reinsurance fee reporting if you are the appropriate entity to do so last November. I believe the payment date for the first installment of the payment date for the 2016 transitional reinsurance fee is due on the 15th of January. And you are, of course, able to pay 100% of that by the 15th, or you can pay it in 2 installments, in which the second installment is due this coming November. But this is something we are not going to have to worry about going forward. The PCORI fee, as you can see, has increased from $2.17 per life to $2.26 per life for plan years ending on or after October 1, 2016, but before October 1, 2017. Like the transitional reinsurance fee, this fee automatically sunsets, but we have a few more years before this sunset provision applies. That will apply effectively when your plan years beginning on or after October 1, 2019, you will no longer have to pay the PCORI fee either.
And perhaps even earlier, right, Tripp, depending on what happens.
Again, I would say that's what these two things are in the minutiae, so they haven't really paid. You know, this hasn't been a big talking point.
I haven't heard a single interview in the national media about the PCORI.
No, right.
Nothing. I'm shocked.
I wonder how many even would know what it stood for.
I know it. So anyway, as you can tell, we kind of breezed through those slides because we wanted to really focus on the legislative proposals. And we are delighted about our timing because, as you all can imagine, there has been so much ebb and flow and change since the November election, you know, going from an immediate repeal on day one to, I think, some pausing on the part of the GOP, realizing that, maybe we should have more meat on the bones in terms of a replacement plan. So lots of things to consider, and I think it's clearer now than it was a month ago, and it's going to be clearer still in another month, I think, as to the direction of all this. But you know, Tripp, as we look at repeal and replace, go back and do a little bit of a civics lesson about how this exactly works. Could the GOP, with their majority, simply repeal Obamacare today, actually? They don't even, well, I guess until January 2020 when Trump takes office.
Most likely, no. They certainly couldn't do it on their own. To have a full-out repeal, they would have to have Democrats in the Senate switch sides, and that's because of these filibuster rules. Essentially, to get through the Senate, a party needs a supermajority, and you'd have to have 60 votes in favor. And I don't think the Republicans would pull off a full 60 votes in favor of a full-out repeal. So what does that mean? It means that they can't repeal it outright, just say everything that about the Affordable Care Act is no longer applies. But what they can do, and this may sound familiar, is use the budget reconciliation process. And the reason that this may sound familiar is the ACA was actually passed through using the budget reconciliation process. And essentially what happens is they use budget bills, so therefore any provision, any statute that they're going to make changes to, whether they repeal, enact, change, has to at least be tangentially related to some type of revenue raiser or expenditure. And efforts to try to promote efficient passing of budget reconciliation bills are what they call filibuster-proof, meaning that you simply need a simple majority to pass that in the Senate.
So Tripp, last night, I know for those of you who have been following the news with great interest on this, there was something that happened in the Senate, and I believe that the vote was 51-48 with Senator Rand Paul joining the noes.
Correct.
What was that vote all about?
So they actually, the Senate last night, being they, voted on whether to pass the budget reconciliation bill, which is essentially a direction to two subcommittees in the Senate to take up the role of beginning to write the repeal of the Affordable Care Act. And again, that repeal can only touch on revenue-related or expense-related provisions. Much to my wife's dismay, C-SPAN has become my new favorite channel, and I watched this till about midnight last night, and they did not actually vote on this until after midnight. They voted on a series of amendments to the budget reconciliation, which none of them passed because they needed the supermajority. But again, because it was a budget reconciliation, the bill overall only needed the simple majority, and as Mary said, was voted in favor 51, with 51 affirmative votes, Rand Paul being the only Republican to vote no. And from my understanding of seeing his Senate debates, was largely because this budget reconciliation is budgeted to add $9.7 trillion to the national deficit over the next 10 years.
A few dollars, yeah.
So the next step now is that as early as tomorrow, the House will take up the same measure of which they vote on a budget reconciliation, and I assume that will also pass, and that bill will direct two subcommittees in the House to begin writing or drafting the appropriate statutory language to repeal the Affordable Care Act. Once those subcommittees are done, and I believe the deadline for them to be done is fairly quickly, is January 27, those bills will then be presented to the full House and Senate.
Right. Now, for those of you who watched President-elect Trump's interview on 60 Minutes the Sunday after he was elected, or maybe saw some excerpts from his press conference, I believe yesterday, you'll know that he has continued to reiterate that there are certain provisions in the Affordable Care Act that have nothing to do with the budget reconciliation process, like prohibitions on annual and lifetime limits, pre-existing condition exclusions, and keeping dependent children eligible for the employer's plan until age 26. Probably doesn't want to undo those provisions anyway, although we will talk a little bit about some of the things under consideration on the pre-X a little bit later during the webinar. But don't forget that there's a lot of chest pounding here, and now that the reality is setting in, I think some of that chest pounding is giving way to what would be a replacement plan. So what we're going to talk about right now is what we do know. So what we do know, these are proposals that Trump made on the campaign trail. You may have also heard that he has said he will have a more specific plan once his nominee for Health and Human Services Secretary, Tom Price, who's a congressman and also a physician from Georgia, is confirmed. If that happens, or as soon as that happens, Trump says he will have more specific proposals. But we're going to talk about right now what he is proposing so far. Also, we'll talk a little bit about what Price has proposed in Congress to give you an idea of what Trump's proposals might look like. So first thing I think that is absolutely clear, and Tripp, I'm assuming you agree with me, is number one priority, eliminate that individual mandate penalty.
Correct. That was I think a vital piece of his campaign trail speeches, and I think that will be something that we'll absolutely see. Again, whether it's funny, with the individual mandate is not technically a revenue provision, so they may not be able to eliminate it, but they could reduce the penalty, for example, to zero, so
right.
Therefore effectively eliminating it.
Right, and I think some of the questions, and we're going to get into this a little bit more, I think, with Ryan's proposals and Price's proposals, but some of the questions then become, what will happen to the exchanges? Probably go away. What will happen to the premium tax credits and subsidies? Will they be reduced? Will they be eliminated? Will there be a substitute? What do you think, Tripp? My guess is there'll be a substitute of some sort.
Correct. Some type of tax credit, whether it be advanceable or refundable at the end of the year, I imagine it will be some type of tax adjustment.
Yeah, and then one of the other big questions is even though we're not going to force everybody into coverage, American voters definitely want access. And so what is going to be the replacement plan to guarantee access and also to guarantee maybe affordability? And so those are some of the unanswered questions that Trump did not get at in his initial proposal. Another area, Tripp, that he talked a lot about on the campaign trail, and we're seeing in some of the congressional proposals, is this idea of buying insurance across state lines. What's the logic behind that one?
I believe his logic is that it would increase competition between the insurers to sell across state lines, and therefore using, the idea would be using the free market would reduce the price and therefore make these policies more affordable. And essentially, I think one of the other things to note is, fully insured policies, individual policies, all have to meet certain state insurance law requirements.
Right.
And if I'm able to sell across state lines, insurers may be able to cherry pick, for lack of better terms, the states that they actually want to issue the policy in based on that state's insurance market reforms or insurance requirements, and then sell that policy in other states as well.
Right. Absolutely. I agree. I agree. There's also this proposal that making sure that the cost of buying individual insurance for anyone is fully deductible. And then, of course, another area that you're seeing a lot of proposals on, both in Congress and from the Trump administration, incoming Trump administration, is to make HSAs more attractive. Here's some of the proposals here, as you can see, Tripp. Tax-free contributions in all circumstances. That doesn't always happen now. Increasing the contribution limits, which we just listed on the slide a few slides ago. Expanding the tax-free distribution rules. Right now, can't I get tax-free reimbursement for all my dependent children?
Well, as not all of your dependents necessarily up to 26. That was one thing that was kind of unique about the ACA. Well, they said, you can be up to 26 and stay on your parents' plan. You essentially have to meet the tax-dependent definition. So whether the mom and dad are able to claim you as a tax dependent on their tax return in order to to take HSA distributions for medical expenses incurred on those dependents' behalf. So really what it did is some of those older dependents may stay on mom and dad's plan, but you can't legally take an HSA distribution to pay for their out-of-pocket medical expenses.
So I'm living with that now. I have a 24-year-old college graduate son on my health plan, but he is not my tax dependent because he thankfully is gainfully employed, and so I cannot be reimbursed for his out-of-pocket expenses under my HSA. That could change that's one of Trump's ideas to change. And then also the fact that, upon death right now, Tripp, I believe that you can only basically transfer that HSA to your spouse.
On a tax-free basis.
And so that would be another change to, again, make HSAs more attractive. I think this is all kind of a shift toward giving more autonomy, responsibility back to the individual. Would you agree?
Correct. In fact, if you have listened to some of the Senate debates going on about this, what we typically refer to as high deductible health plan / HSA arrangements, the senators are seeming to refer more to as catastrophic plans, combining with an HSA that will assist people pay for minor, out-of-pocket expenses. But then that high deductible plan, that catastrophic plan, is there in place, presumably cheaper from a premium standpoint, to cover the individual should they incur major medical expenses.
Yeah. And also I think kind of this feeling of, since that HSA has that, rollover carry forward feature, that maybe this is also a vehicle to help individuals better save for their health costs in retirement, which is another obviously big problem with our Medicare system and how we're going to finance that. So you're going to definitely see these themes of making HSAs more attractive, and we're going to now talk about that a little bit later in terms of the congressional proposals as well. Some other ideas that Trump has floated: he wants to provide more price transparency from healthcare providers. And Tripp, boy, oh boy, don't know how he's going to get that done.
Yeah, that's a good question. I think we'd all like to see that, to be honest with you, but I don't think that's an easy thing to just make happen.
Right. If I go to the hospital for a service, what I'm charged is probably varying based on whether I'm in Medicare or one insurer's plan with a network or another carrier or Medicaid, and the prices for one procedure may vary depending on the funding source. There's also this idea of providing more autonomy to the states. So right now, the federal government establishes Medicaid, which is, of course, health coverage for lower-income Americans, and the federal government mandates this. They provide funding to the states to do so, but there are parameters and guidelines. This idea of block grants is to say, you know what, maybe states, you know what you're doing better on the design of the program, the delivery of the program, so maybe we'll just give you money and give you the discretion to do it. The other, I think, fascinating question, Tripp, is one of the controversial aspects of the ACA was to expand Medicaid, which really enabled a larger segment of our lower income workforce and non-workforce to obtain coverage. In fact, maybe arguably even more than those going to the exchange. What do you think is going to happen there on the rollback? Will there be a rollback of Medicaid, or will it be mandatory?
I think we will see a rollback of Medicaid, at least the expansion. So remember, the expansion was not mandated on the states, but it was basically going to be 100% federally funded, at least for the first couple of years, and then back down to 90% for those states that opted to expand Medicaid. And many states, both controlled by Republican governors and Democratic governors, chose to expand Medicaid. I do think we're going to see a rollback, at least of that expansion, but replaced again, whether that be by some type of block grant or some other funding mechanism, of where I think the federal government says, under the Trump administration, we want Medicaid to be run in the state's purview. The federal government wants to get out of that.
Yeah. I think the other thing that this proposal kind of highlights is a general theme. I think a general theme of the Affordable Care Act is we want the most number of people, the greatest number of people to be covered, to have insurance. That's how we believe healthcare costs are going to be under control. I think that a lot of the Republican proposals you're seeing are not focused on penetration of coverage, rather are focused on access to coverage. In other words, giving the individual more choice to decline if they want to. So that, whether you agree with one side or the other, that seems to be a little bit of the distinction. Now, this last point, and Trump did raise it in his press conference yesterday, and I think shortly afterwards, the stock prices of several prescription drug manufacturers went down. But I think this is a populist idea.
I believe his comment was, pharma is getting away with murder. And what's interesting, again, is, never let a good moment or a good quote go unused. Senator Sanders grabbed on this right away in one of his Senate debates, and actually it totally agrees with Trump at this point that we should be allowing drug imports from foreign countries. In fact, he told a story about how he took a bus full of residents of Vermont over to Canada to purchase prescription drugs, and he had a chart in his Senate debate that compared some of the prices of prescription drugs available in the United States versus Canada. And when you look at it this way, it seems, why would we ever not allow this? But as I believe it was Senator Mike Enzi from Utah got up and said, this is not something that we haven't explored before, but what we are concerned about is once we open the doors to foreign prescription drugs, we don't necessarily know what countries they came from. We have faith that prescription drugs from Canada are very, very safe, but once you start allowing people to buy these on the internet, they could come from countries where these prescription drugs are not safe at all.
And then, of course, the prescription drug manufacturers here in the U.S. will also be a little bit upset because they claim that the reason that they charge so much is because of all the R&D that they do, and that, boy, that important research and development may go away if they have to now compete with other country drug manufacturers that don't similarly subsidize their research and development. So right now I can go to Canada myself and buy my own drugs. That is permitted. But I can't go to Canada and buy a bunch of drugs and come back here and sell them. So just that's the current state of the law right now.
It's not legal.
Right, and we'll see. Yeah, marijuana maybe, I don't. But anyway, so we'll see what happens with all of that. But that's kind of a more of a populist provision that's not really in any of the congressional proposals that I've seen. So we're going to talk a little bit about, and as Tripp and I were getting ready for this, folks, they're contrary to the rhetoric that you're hearing in Congress right now. There have been several proposals already put forth by multiple Republicans to repeal and replace. We've looked at many of those thus far. I think we're going to see something more specific coming out in short order, but we already have a good idea of what a lot of those are. And as I mentioned a few minutes earlier, President-elect Trump has indicated that once his HHS Secretary nominee is confirmed, that he will be putting some more meat on the bones on his proposal. We're going to talk right now about Speaker of the House Paul Ryan's proposal. And as we go through this, I will mention a few things about Price's proposals that he has made in the House of Representatives thus far. My view is that Ryan's proposals and Price's proposals are very similar, and if they are very similar, that is interesting because how will that inform Trump's eventual proposal? So with that, let's first talk about the individual mandate. Yes, Paul Ryan would eliminate it as well, but here's where one area I want to just stop at Tripp, with you, and that is, you mentioned this a little bit earlier. Right now we have this premium tax credit, and then we have subsidies for low-income people to help pay for their deductibles and copays. Paul Ryan wants to get rid of that and replace it with an advanceable refundable tax credit. What is an advanceable refundable tax credit?
Well, let's break it down. I mean, and let's take the refundable portion first. You can have a refundable tax credit is essentially saying, even if I don't owe any tax and I have this refundable tax credit, I may get a tax return back. Where a non-refundable tax credit says, okay, I may be eligible for this $1,000 tax credit, but my tax liability is already at zero, so I effectively can't use that $1,000. So regardless of what an individual's ultimate tax liability, the fact that it is refundable will mean that those individuals will, in fact, see a tax run. And if you think about lower income individuals, they may not be able to wait until they file their tax return the year after and then wait till they get that tax refund in order to pay for insurance that they previously used. So the idea of it being advanceable is much like the premium tax credit, where it says, hey, you don't have to wait until you file your tax return to take advantage of this credit. We're going to make it advanceable. We're going to make it available when you need it now. And then presumably, like the premium tax credit, there would be some type of reconciliation on your tax return. So maybe if you didn't use as much as you were entitled to, you get a little bit more back. Or if you use more than what you're entitled to, maybe you actually have to pay, or more likely even, if you were entitled to a refund, that refund would be reduced by that amount of excess.
Another thing that an observation that I've seen about this concept and how the two compare is that the premium tax credit is also tied, the current one under the ACA, is really kind of tied to the cost of health insurance on the exchange. So in other words, as that goes up, that is adjusted, so the low-income person will get a greater tax credit. The Ryan proposal is more of what I call a defined contribution approach. So those of you on the call today that are involved with the retirement benefits at your shop, you know that a defined benefit pension plan replaces income. A defined contribution approach for a retirement plan says this is how much we give you, and you're on your own for the rest. The Ryan proposal apparently is more of a defined contribution approach for the premium for this advanceable refundable tax credit as well. And I will point out right here that Representative Price's earlier proposals did have some adjustments in his similar advanceable refundable tax credit idea, adjustments for inflation, adjustments for age, but again, not necessarily adjustments for the average cost of coverage, or at least to replace the total increases in the average cost of coverage. Some other ideas, Tripp, there. I see that he wants to buy insurance across state lines as President-elect Trump. And then this is kind of an intriguing idea. If the cost of insurance is less than the credit, that the deposit would be balanced in an HSA-like account. Don't know if you have any thoughts on that.
I think it's a unique idea, one that we certainly haven't seen before. And what strikes me is how would this work? I mean,
right.
In theory, it seems like a great idea, but I just wonder, in practice, how does it work?
Yeah. And then the other thing I think that's interesting here is, would there be this guarantee of a continual no pre-existing condition exclusions or limitations in plans? Not so sure if Paul Ryan embraces that.
It seems like the Republican proposals are while it seems like everybody embraces the idea of the pre-existing, of removing pre-existing exclusions, the method that the Republicans seem to approach is the old HIPAA rules, where we require some continuous coverage and only allow exceptions for very brief gaps. And if you do go a gap, you have a limit. The insurance company has a limitation on how long they can impose that pre-existing condition exclusion. Again, I think that if you think about some of the differences in philosophies between Republicans and Democrats, I think that the idea there is almost putting more personal responsibility on the individuals rather than the government saying, you have to do this.
Yeah, and I think also just the whole idea of isn't that an incentive enough to carry coverage? In other words, we don't need to impose an individual mandate penalty if you know that you need to be continuously covered in order to make sure you don't have a pre-existing condition exclusion.
Yes, and there was a study that was done by Rand Group that said that a pre-existing exclusion, enforcing pre-existing exclusions, may actually be a bigger incentive than a pay-or-play penalty to maintain continuous coverage, theoretically. But in practice, again, I think it acknowledges that not everybody understands all of this stuff and therefore may not know that they have to maintain this continuous coverage. Otherwise, when they go to buy coverage when they get sick, they may not get coverage for that particular sickness for a number of months.
So there's also some kind of stopgaps here, as you can see. In any event, he would want to make sure that insurers would require individuals to be able to enroll at least annually and following certain qualifying events, loss of coverage, new baby, blah, 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 and to cap premiums at what he calls standard rates following a qualifying event. The logic there being, we don't want, you can get in, but we don't want to really jack up the price so you can't meaningfully afford that. There's another proposal that's common to both Ryan and Price and some of the other GOP proposals that say, okay, we're going to get rid of these exchanges, but we're going to have high-risk pools. This is something that's happened in the past in some states. Tripp, well, how exactly does this work?
This is a pool that is effectively open for people with, high claims, with those pre-existing exclusions, which is a number of Americans. That is federally funded and specifically geared toward providing coverage to those high-risk individuals while they can't obtain other coverage through the market or other government-provided coverage, whether that be Medicaid or Medicare.
And the beef, the criticism about this is this has been tried in the past pre-ACA, and that oftentimes the problem is that the coverage is lousy, very expensive. It's kind of the last resort for people. So it would be a stopgap, but it wouldn't necessarily be an attractive stopgap for certain people. I think another theme that you see in all of this is that there are winners and losers. And here's another example of that. Right now, under the ACA, there are restrictions on how much an older person can be charged relative to a younger person. Basically, the age ratio spread is 3-to-1. And if you, now I'm not an actuary, but I did stay in a Holiday Inn Express last night, Tripp. But my understanding from actuaries is that that is an unrealistic spread, and that it's really more like 5-to-1. Paul Ryan would go with that 5-to-1 spread, which of course is going to be a winner and music to the ears of younger people, but then older people could be disadvantaged by this.
True. But I think one of the problems with the ACA is even with that individual mandate, they did not see the number of young people enroll in exchange coverage that one, they expected, and more importantly, two, that they needed.
Yes. So you need those young, healthy bodies for your pool. And again, like President-elect Trump, like Representative Price's proposals, Speaker of the House Ryan would also focus on HSAs, wanting them to be more attractive. He's got some other kind of different ideas, though, than Trump. So, for example, right now, if I am in a high-deductible health plan and my spouse is enrolled too, my spouse can go out and make a post-tax contribution to an HSA, coordinating the limits with me, but this would basically allow the spouse, you to basically make an additional catch-up contribution for the spouse where the spouse is at least age 55. And then also another trap for the unwary that I've seen is sometimes the person enrolls in a high-deductible health plan, but they don't get that HSA set up quite in time. This would allow the HSA to reimburse qualifying expenses if they were incurred shortly before the HSA was established. And also we're looking at increasing the contribution limits to make sure that you can always contribute to the up to the maximum of what your maximum deductible and out-of-pocket would be. Similarly to the Trump proposal, Paul Ryan would look at delivering more power back to the states on Medicaid funding, either doing the block grants or some type of per capita allotment funding. But again, the whole idea is to give more autonomy back to the states. These next two proposals, Tripp, again, maybe we can talk about what the rationale for them is, allowing small employers to pool together to offer health coverage. What's up with that?
This is not necessarily a new idea. It's what's often referred to in our industries called a MUA, or a multiple employer welfare arrangement, and there are certain which we always typically advise our clients to stay away from because of the state regulatory requirements that they have to comply by. There are currently exceptions for association plans, and I think this bill's done that. The problem being is there still are some practical difficulties, some hurdles to jump over to establish a MUA, an association plan. But the ultimate goal would be is to allow some small employers to band together to either purchase insurance coverage or possibly provide a self-funded coverage, much on the same level that a large employer is able to do. And therefore, it really just simply spreads the risk amongst a greater amount of people like a large employer can do, but that doesn't necessarily isn't able to do the small employers can't take advantage of on their own.
Right. And similarly, right now, some particularly employers that self-fund are looking at establishing captive arrangements to basically finance their stop-loss coverage, or joining other employers in captive arrangements to try to have more cost-effective stop-loss coverage. That's another proposal. Some of his Medicare proposals are not controversial, like combining Parts A and B and capping individuals' out-of-pocket costs. But Tripp, this one I've seen also labeled as a voucher program. Paul Ryan, I think, would like to see us really make some significant changes to Medicare. I haven't seen really any of the other proposals willing to bite this one off. Do you think it's feasible?
I don't. In the current situation, again, I think creating a Medicare voucher program, regardless of what your feelings on that are, would be difficult, because to me that seems like a provision that they would need to get through, have 60 votes in favor for in the Senate, and I just don't think, Medicare and voucher seems to be a naughty word for Democratic senators, so I don't know if he would have the support. Yeah. I think the fear is maybe it starts out okay, but several years down the road, my voucher is $9,000 and my Medicare plan is $21,000, and I'm not anywhere close to being able to afford it. I think that's the concern.
And I don't think Trump's going to get behind this one either, folks, because remember, he's got that populist aspect of his philosophy. A couple other things very, very quickly. For those of you who have a wellness program, you know that there were originally these HIPAA Affordable Care Act wellness program rules that most employers weren't crazy about but could live with. And then the spring of 2016, the EEOC added additional rules under the Americans with Disabilities Act and GINA that really made wellness programs a lot more difficult to offer in a meaningful way. Paul Ryan for sure recognizes that. I would not be surprised to see some rollback of some of those requirements to make wellness programs a little bit more viable and robust going forward. And then, of course, the constant Republican olive branch to healthcare providers of malpractice liability reform, which is kind of a bread and butter proposal.
Yep.
Some other things that I've seen, okay, so if the employer mandate doesn't go away, what would be a fallback? Well, one fallback might be to say we're going to modify the definition of full-time from 30 to 40 and simplify the reporting. What do you think, Tripp? Do you think these are going to be the outcome, or do you think it's just a total repeal?
I actually think that they'll strip the employer mandate, whether they strip it out or they drop the penalty down to zero, will be effectively what happens. Ultimately, though, I don't know how much that will affect the coverage that a lot of employers are providing. I don't hear a lot of complaints from employers saying, I don't want to provide these coverage to people. What the complaints are the rules that come along with it. So, if you're one of those employers that uses these look-back measurement method periods, and you have someone that moves from full-time to part-time, when can I cancel their coverage? Or they go out on a non-FMLA medical leave, and the benefits attorney says fire them, terminate their employment. The employment attorney says, whoa, wait, and it just becomes you're between a rock and a hard place.
So Tripp, if they do repeal, which I agree with you, I think is probably the more likely outcome, do you think we're talking, 2017? Do you think we're talking effective 2018, 2019? What do you think?
I think it's a great question. In fact, I believe it was the Price's plan that would retroactively appeal. I mean, remember, we haven't seen any assessments, at least that I'm aware of. I don't think that they've assessed any pay or play penalties. I don't think they're just now getting all the information that they have, and the IRS has limited resources, which we know. So I think it's theoretically possible that they could repeal this provision retroactively back. So, we went through the reporting nightmare. It ultimately was all for naught because there's no penalty. So I don't know that will happen, but it seems like our range could be retroactively effective now, or maybe some transition period where we have to comply with it and for another year, another 2 more years, or what have you.
And then also, of course, remember the Cadillac tax. It was initially supposed to start in 2018. Last year they moved, or December of 2015, they delayed it to 2020. There's been talk about delaying it further, modifying it, repealing it. One of the big problems, though, is replacement revenue source.
I think the Cadillac tax, though, has just been taken off of life support. I think it's gone, and now the problem will be how do we replace the revenue? Yeah. Because this is a provision that I think a lot of Republicans and Democrats agreed with each other that they didn't like.
Right. But what's really interesting here, folks, is both the Ryan proposal and the Price proposal would cap the employer's deduction for group health coverage. So if you are a non-tax exempt employer, you take a deduction for the cost of providing health coverage. He would cap it in both plans, which would kind of get you to the same place. And
it's not an attractive proposal, at least from what I hear right now, but I think if you look at this at the greater scope of things, you were going forward with the Cadillac tax and the pay or play penalty. It was going to be a pick your poison. Which excise tax did you want to pay? Yeah. And the reporting requirements for both, as most of you know, the reporting requirements for the pay or play penalty were challenging. It was looking like the reporting penalties for the Cadillac tax were going to be even more challenging.
Yeah.
And at some point, I think employers almost got to, I'd rather just pay the tax if the reporting was easier. And this is effectively the answer to this. Yeah. A limitation on your deduction for group health coverage is essentially paying the tax with virtually no reporting.
Yeah. So anyway, we'll see what happens. But that's the reality, guys, is, okay, we repeal and we replace, but what do we replace with? And it's not just replacing with to make Americans happy about their choices. It's also how do we navigate all of this within our budget, which is a lot of these changes would really cost a lot of money if we don't replace them with something. And then just very quickly, I want to mention that the other kind of peripheral proposals would be to make, remember that we just had this qualified small employer HRA added in December, but there's been some kind of ACA limitations on HRAs. I think we're going to see a rollback to make those more viable. FSAs, similarly, I think we're going to see an increase in the contribution limit for FSAs. And also remember that right now I can only get reimbursed for over-the-counter drugs if I get a prescription from my doctor or it's insulin. This is talking about going back to some old rules to allow OTC reimbursement across the board. So finally, Tripp, the last two slides we've got here before we open it up for some questions are talking about the fact that the Trump administration can maybe get to the same place on some of this ACA stuff simply by their own power through the the administrative branch of the government. How exactly will this work?
I think the best way to explain this is kind of by example. Remember, folks, the pay-or-play penalty was supposed to take effect in 2014, but it technically it did.
You didn't really have to worry about it.
But you didn't have to worry about it because there was an announcement in late 2013. I think it was actually in July of 2013. I remember where it was when I got the email on my phone. And at that time, and President Obama at that time said that he's basically issued a directive to the IRS not to enforce the pay-or-play penalty or the reporting requirements for 2014. So I think the same type of concept applies where President-elect Trump would tell his commissioner of the IRS, or if it fell in the IRS's purview, or his Secretary of Labor, if it fell in the Department of Labor's purview, is don't enforce these rules.
Right.
So while they're still effective, the penalties for noncompliance don't exist.
Yeah, and then we also have all kinds of projects in the pipeline that may not go anywhere. Like there were some proposed 5500 regulations. There was a project to issue Cadillac tax regulations, 2 requests for comments that were issued. There's some regulations that were supposed to go out explaining the impact of cash outs for health coverage on affordability, non-discrimination regs on fully insured plans. All of that stuff was in the pipeline. It's probably not going to go anywhere now.
I agree. I don't know what else to say.
Yeah. And then also, there's been a couple other things just want to very quickly mention. Contraceptive coverage and transgender health benefits. And boy, Tripp, we've seen some activity on both of these in the past couple of weeks. What's your crystal ball on whether employer group health plans will have to offer contraceptive coverage or transgender health benefits?
It seems like while I would have said a few days ago, or especially a month ago, we were moving in the direction that these were absolutely going to be requirements. It seems like we may be now reversing courses, and that group health plans will, like they have historically been able to do, have their discretion about whether they want to provide these types of coverages.
So for now, other than the injunction, of course, on transgender, but for now, the contraceptive coverage requirements are in place, but don't be surprised if there are some changes.
There was a significant development, as Mary said, with respect to a court injunction on transgender health benefits and what we refer to as the Section 1557 final regulations. In the interest of time, I will just refer you to the client alert that I believe went out yesterday from Miller Johnson on that subject.
Yep. Okay, well, thank you for your patience. I think that I know we are right at 11 o'clock now. We were hoping to be done by 11 o'clock, but even so, if we have a few questions, Amy, I think we do have time for that. And it looks like we do not have any questions.
Just administrative.
Just administrative questions. So again, we really appreciate you joining us today. Glad you could be with us. Glad for our timing. Miller Johnson is going to be all over the developments that go on right now, as we have been in the past. Continue to look for our client alerts, our subsequent webinars, and we are glad that you're partnering with us as your compliance solution. So have a great day.